Hello, everybody, and welcome to this edition of the ATS Pulmonary Rehab Assemblies Journal Club. My name is Lindsay Houchin-Wolloff. I'm the Assembly's Web Committee co-chair, and I'm a research physiotherapist from Leicester Hospitals in the UK. So before I introduce today's article and panel, I'd just like to ask that you mute yourselves throughout the session as the session is recorded. When we reach the discussion segment, we'd like to have a lively discussion, so we'd appreciate any questions or comments that you have using the Q&A function. The article we're discussing today is entitled Singing for Lung Health Following Completion of Pulmonary Rehabilitation, a Feasibility of a Randomized Controlled Trial. Today we're joined by the lead author, Adam Lewis, who's an associate professor in physiotherapy from the School of Health Sciences, University of Southampton in the UK. Lipisha Agarwal, Pulmonary and Critical Care Fellow from the University of Vermont Medical Center in the US, will present the article today. And we're delighted to have our expert panel. This is Samantha Harrison, Professor in Respiratory Rehabilitation from the School of Health and Life Science, Teeside University in the UK, and Mette Kaasgaard, Associate Professor from the Faculty of Health Science, Zealand University Hospital in Denmark. We're also joined by Daniel Robledo from the ATS staff. So I'll hand over now to Lipisha to present the study. Thanks, Lipisha.
Thank you, Lindsay. Good afternoon, everyone. I'm Lipisha. I'm one of the fellows at University of Vermont in Pulmonary and Critical Care. Today, we'll be discussing a recently published feasibility study from BMJ Open Respiratory Research examining whether a randomized control trial of singing for lung health following pulmonary rehab completion is feasible. And as we go through this, I'd like us to critically think about what makes a feasibility study successful and what it means for a future definitive trial. So let's start with the clinical problem. Chronic respiratory diseases, as we know, are a leading cause of mortality and morbidity worldwide. And despite optimal pharmacological treatments, many patients remain disabled from physical limitations and social isolation. Pulmonary rehab is actually our gold standard non-pharmacological intervention. However, and this is the critical point, the benefits of PR decline over time. Evidence suggests that maintenance programs can help, but we don't have an evidence-based consensus on what the optimal maintenance strategy should be. And importantly, patients themselves identify the lack of a fun group environment as a barrier to ongoing engagement, and home-based maintenance options have not performed as well as in-center options. So there's a real unmet need here for something that keeps patients engaged in a group setting and physically active after PR. So this is where Singing for Lung Health comes in, or SLH. It is a creative health activity specifically designed for people with respiratory disease. It's not just casual singing. These are structured sessions led by trained leaders that address physical, mental, and social needs. Singing involves postural and breathing support and vocal technique. And SLH differs from generic singing by its specific focus on improving breath control and posture in relation to respiratory disease. The rationale for positioning SLH after PR is also compelling. Patients who have just completed a program where they've gained significant health benefit and experienced the value of a group environment. And SLH could maintain that momentum at this critical transition point. There's also some preliminary evidence to support this, and a recent study found that PR completers who participated in singing as exercise during PR were significantly more likely to report improved breathing nearly 5 years later compared to those who did standard resistance and endurance exercises, which was like 40% versus 22%. And that's a striking long-term signal, though of course it's observational data. So the aim of this study was pretty straightforward. It is to investigate the feasibility of conducting an RCT evaluating 12 weeks of SLH exercises compared with usual care for people with chronic respiratory diseases following PR completion. The research question was specifically in people with COPD, asthma, ILD, or bronchiectasis who have completed PR, is an RCT comparing once weekly SLH to usual care alone feasible for participants to complete? Crucially, this was not designed to test effectiveness. It was designed to test whether the components of an RCT would work so that a definitive clinical and cost-effective study could be optimized. And this distinction is obviously important as we evaluate the results. We're looking at whether the machinery of the trial works, not whether singing definitively improves outcomes. So the investigators conducted a parallel group assessor-blinded randomized controlled feasibility study with a nested qualitative component. And note that the breadth of the respiratory conditions included, COPD, asthma, ILD, and bronchiectasis. This wasn't just a COPD study. And this paper was written in accordance with the Consort 2010 extension for pilot and feasibility studies, which is the appropriate reporting standard. And the study was prospectively registered, which also adds to its methodological rigor, sorry. So coming to participant enrollment, 4 PR centers in London that followed the BTS quality standards and had SLH groups in their locality participated. Enrollment occurred between October 2022 and November 23. So this was conducted in a post-acute COVID period, which is relevant context for some of the challenges that we will discuss later on. The recruitment pathway was as follows. After their baseline PR assessment, patients received a brief information leaflet. PR programs were also asked to include an SLH taster session as part of their education program. This included a PowerPoint introduction and a live demonstration of what SLH exercises would look like, and that everyone was encouraged to join. Potential participants were then invited to screening and assessment no later than 1 month after PR discharge. All sites were part of the London PR network, and a maximum of 15 participants per SLH group was allowed based on venue risk assessments. The rolling nature of PR programs is also important to note as it affected group sizes. The eligibility criteria are also worth examining carefully because they significantly impacted recruitment. On the inclusion side, participants needed to be at least 18 years old and have received 3 COVID vaccines plus influenza and pneumococcal vaccines. They should have had a clinical diagnosis of COPD, asthma, bronchiectasis, or ILD, and have stable respiratory health for 4 weeks, have completed at least 8 sessions of PR, and were able to consent. The vaccine requirements were added following, research ethics committee review early in COVID, and excluded 107 out of 100 out of 1,300 screened patients, which is about 8%. The authors also noted that this could potentially be dropped in a future study since patients can complete group PR sessions without these vaccines. On the exclusion side, prior SLH attendance, regular singing group participation, and life-limiting comorbidities were like the main exclusion points. The PR completion requirement of at least 8 sessions is notable. Non-completion of PR was one of the largest reasons for ineligibility, accounting for about 470 patients. The study investigated a range of measures around recruitment and retention that might determine the feasibility of a definitive clinical trial. The primary feasibility outcome was completion of 12 weeks of SLH group classes, defined as attending at least 8 out of 12 sessions. The pre-specified hypothesis was that 60% of these individuals randomized to the SLH arm would meet this threshold. This is a reasonable benchmark for a feasibility study. It's asking whether people will actually show up and engage with the intervention. If fewer than 60% completed, then you'd have serious concerns about whether a definitive trial could work. So keep this 60% number in mind as we look at the results. The secondary outcomes were extensive and covered feasibility, clinical, mechanistic, and health economic domains. On the feasibility side, they looked at eligible participants completing PR, rate of PR completers entering the trial, taster session implementation, recruitment rates per site, home exercise diary recording, and physical activity monitoring. And then health economic data was collected using cost questionnaires and the EQ5D5L at baseline, 12 weeks, and 24 weeks. And then in terms of clinical outcomes, these included the incremental shuttle walk test, lung function parameters, the short physical performance battery, physical activity data, and then disease-specific quality of life questionnaires. Maximum phonation time was one of the mechanistic outcomes. They also tracked control arm retention at 24 weeks and conducted qualitative interviews. So this is a pretty comprehensive set of outcomes, which is appropriate for a feasibility study, sorry. They're essentially stress testing every component of a future definitive trial.